Good morning.
Good morning, Professor. How are you?
How are you, buddy?
Very good, very good. So people coming early. That's a very good.
Yeah, sure. I just want to make sure that everything is set.
Same here. Yeah, that's perfect.
It's a big responsibility. I know you're doing a great job, buddy.
Thank you, Professor. It's a pleasure. Waiting for Dr. Aazh and Dr. Hashir and Dr.
Yeah. Just send a note that to everyone to turn off their microphone.
Good morning, Ollie.
Good morning. Richard, how are you?
I'm fine, thank you.
All right.
How are you, Professor Richard? Welcome.
Thank you. Thank you, Mohammed.
One of your students before, or fellows, if you remember him, his name Mohammad al-Badri from Egypt.
Yes, I do.
Yeah, he's sending his greetings for you. And he will do his best to join the meeting. But
okay.
Asked me to send his regards and told many great things about you, sir.
Thank you. Where is he working right now?
I am working in Saudi Arabia. I'm working in Saudi Arabia, director of Hearing and Balance Clinic at King Abdulaziz Medical City, one of the top hospitals and tertiary care referral center. It's a military center, that's why you have a lot of tinnitus patients. Dr. Moahamd Al-Badri, now he's a professor, full professor, and head of audio vestibular unit at Almenia University, Egypt.
Okay.
Dr. Alfarghal, can you see my screen?
I can see, yeah, but you
Okay.
didn't share any PowerPoint. I see your video yourself.
Do you see my PowerPoint?
Not yet the PowerPoint. Please use share screen. Open the PowerPoint first, then share the screen.
Yes. Just want to make sure that everything is working. Do
Yeah,
you see it
now it's coming, bro.
Okay, very good. So I'm going to stop sharing. I'll wait for everyone to join, and we'll let so let me see. Okay, so I'm set. Dr. Salvi, can you share your screen with us, please, for a second?
Okay. Can you see that?
Yeah, excellent. That looks good. Just if you press like when you, well, yeah, we'll have the full screen when you, yeah, that's wonderful. Great. So, good, you can just stop sharing now. I'll wait for Dr. Aazh.
Yeah.
Good morning.
Good morning, Dr. Hashir. Welcome.
Thank you. This is Dr. Emmett Gotsalia in Los Angeles.
Okay. How are you, sir? Nice to meet you. So, Dr. Hashir, are you on board? So you can try sharing your screen. He's not yet ready.
Is this going to be recorded?
Yes, sir, if you don't mind.
Yes.
We have our YouTube channel because of timing differences, so many people cannot come on for the live meeting. So they ask just to get the recording and post in our YouTube channel so they can watch.
I'm sorry, I'm back.
Welcome, Professor.
How do I?
Okay, hi.
Hello. How do
Dr.
I?
Aazh, how are you?
I'm fine, thank you. You okay? Can you see me?
Not yet.
I made you co-host, Dr. Hashir, so you can share your screen. You can do a trial.
Let me see. How do I? Oh,
Yeah,
okay.
we see you now.
Can you see me now?
Yes. And can you do us a favor, Dr. Aazh, and share your screen with us? We want to make sure that everything is set for before we start. Okay, excellent. We can see your screen. And yeah, you can stop sharing now. That's good. Dr. Moahamd, I keep admitting people, so
yeah. Keep on. I will take care of that, Professor. Don't
you
worry.
take care of it. Okay. So
do we stay with the video on, or only when we do our talk?
If you have video during your presentation, you can put the video on. But once other speakers they started, we'll make it off. That's a guarantee better signal for the audience. So we turn our mics and our videos. That gives the speaker the full signal.
Excellent.
People will keep joining. We'll start on time. So we have 5 minutes more.
And do we, for the presentations, do we have the question and answers within the time allocated, or that will be after that?
Let's to ask Professor Ali. We take the questions after each presentation, or we keep all at the end? I think it's better after each presentation. We can keep 5 minutes. Then at the end, we keep 10 minutes or 15 minutes for the questions. Do you agree, Professor, or what do you think?
yeah, I agree. I apologize. I was typing. So I'm trying to put it in a way that we can use the 2 hours allocated time to us very effectively. So I guess I will be reviewing the chats. So if the questions come, I will kind of bring it to the presenters. We have a very limited time. So after Dr. Salvi's presentations and Dr. Aazh and mine and yours, we'll give around 5 minutes for questions. And at the end, if I can have like another 5 minutes toward the end, So we'll try to answer the remaining questions. But after each presentation, we'll have like around 5 minutes of questions and answers.
That's perfect.
And all of the presenters have access to the chat room. So you can actually, after your presentation, you can look through and see which one of those questions you feel feel that it will give us enough information for the 5 minutes that we have. We will start sharp at 9 o'clock to use the time as much as possible. Good morning, everyone. This is sharp at 9 o'clock. I want to welcome all of you to this presentation and workshop. I'm honored to host our speakers who are well known to many of us. And I'd like to start an introduction. And then after that, I will introduce our presenters and we'll go from there. So the title of this workshop is Tinnitus and its Management for the Enthusiastic and Caring Clinicians. That means that if you really care about your clinician, your patients with tinnitus, that's the reason that you are here, in my opinion. Because many of us, we do really respect our patients and we want to do something for them. And I'm so happy to host this workshop for you. So we have 4 presenters. We have Professor Salvi, that I'm gonna introduce him in a second, a little bit in more detail, and Dr.Hashir Aazh and Dr.Alfarghal Moahamd. And we are gonna have a basic introduction to tinnitus by Dr. Alfarghal. I have had the pleasure of having Dr. Alfarghal as a friend for many years. As you know, he's a very active clinician. He has published many papers. He has presented in many conferences and workshops. He has this big group of 20,000 people, followers on Facebook in audiology and hearing sciences, which is unheard of. And I want to congratulate him. He has a doctorate degree in medicine and a doctorate degree in audiology. He's an audiovestibular medicine specialist, and with very enthusiastic personality towards his patients. So I would like to invite him to start his introduction, and after that, we'll join by Dr. Salvi for his presentation.
Professor, I prefer, I told you yesterday, just give me one talk. I will do all together. So you start by Professor Salvi, then
Okay.
I will do one lecture one time, so it's better.
Okay, just whenever you are ready, just let me know.
I am ready,
Just,
but we'll do like a 15 minutes, one shot, one time.
Okay.
I replied to the email yesterday.
Okay, sure. So we'll start with Dr. Salvi then. So this is my pleasure to host Dr. Richard Salvi. I have had the honor of his friendship for many, many years. I have hosted his workshops and presentations in Florida also. And Dr. Salvi, there are not many people who do not know Dr. Salvi actually. Dr. Salvi has been known by many, many scientists and clinicians around the world. He's one of the top-notch scientists in tinnitus and its pathophysiology and physiology. He's a professor in University of Buffalo in New York, and it's my honor to host him for this presentation. His talk is about the animal models of tinnitus and hyperacusis. And I think that Dr. Alfarghal, you're recording this presentation, correct?
Yes, Professor. Recording is going on.
Okay, excellent. So go ahead, please, Dr. Salvi, start your presentation.
Okay, I have to share my screen, correct?
Yes.
Can you see that? No.
Not yet.
Any luck? No?
No, if you do not have it, I have it ready for you. I can share mine and I can just, you hint me, I can change the slides for you.
Okay, why don't you just do, let's see. I'm clicking on the shared screen. It's not showing up, huh?
I do not see your screen.
Now?
Yes, I do see it now.
Okay.
Thank you.
Okay, so we're all on board, right?
Excellent, yes. I'm gonna turn off my microphone.
Okay. I'm at the end of my talk rather than the beginning, so I'll go back to the start. So my talk will be on hyperacusis and tinnitus today, and we've been doing most of our recent work on hyperacusis, mainly because we have very good animal models, but I'll give you a little bit of background information. Many of you already know this. The phantom sound of tinnitus, if you look at the literature, approximately 12% of adults experience that, but only about 1% have really severe tinnitus. These are the patients that actually come in to see audiologists and otolaryngologists. So common causes of tinnitus are presbycusis. If you look at the data, people that get into the age range 40, 50, or 60 years, those are the people that are most commonly seen in clinics. If you look at young people, noise trauma is probably the biggest cause of tinnitus. And this comes about from going to loud concerts or being around shooting weapons. In the military, the combat personnel, the people that actually go out and do the fighting, there have been some estimates that upwards of 50% of the people have tinnitus. In the United States, if you're a veteran of the military service, you are seen in a hospital, the Veterans Administration Hospital. And if you have tinnitus, you can get compensation for your tinnitus. And we think about all the things that could happen to combat personnel. It turns out that compensation for tinnitus is the #1 disability. And a few years ago, the US government paid out more than $2 billion in compensation because they have so many people with tinnitus or tinnitus. Hyperacusis is another problem that sort of goes along with tinnitus. If you look at the prevalence of hyperacusis, it's about 9%. And if you look at people that have hyperacusis, probably about 80% of them or so have tinnitus. If you look at tinnitus patients, approximately 40% have hyperacusis. One of the problems with hyperacusis is many people are unaware that they are intolerant of loud sounds. So that's one of the reasons the statistics are probably not accurate. People have it, but they're not aware of it. Hyperacusis also comes with a number of other neurological disorders. People with autism have it, fibromyalgia, migraine, Williams syndrome, chronic pain, and a whole host of other neurological conditions. So on the bottom here, I have data from a gentleman from California. He's a financial advisor, and he has pretty severe hyperacusis. And on the bottom here, I've got the uncomfortable loudness level, sounds that make him feel like just too loud. So at 125 hertz, sounds around 40, 45 dB are just too loud for him. As you can see, as you go up to higher frequencies, 8,000 hertz, he can tolerate sounds around 65 dB. I was at a conference earlier this year with this gentleman, and during the meeting, he had to go and sit in a separate room because it was just too loud for him. So we're going to look at some of these conditions now and some of the animal models. So one of the things I'm going to do is I'm going to take you through the entire nervous system, not only the auditory system, but other parts. We're going to be looking at the cochlea, where damage usually begins with hearing loss. The output of the cochlea is relayed to the auditory nerve, and it goes into the cochlear nucleus. There's a couple of nuclei here. This is all unilateral at this point. All the information stays on the same side of the brain that the ear is on. But as you get up to the superior olivary complex, the information crosses over. Then it goes up to the inferior colliculus. This is a binaural processing area. The medial geniculate body, which is part of the thalamus, that's also a binaural processing area. And then up here to the auditory cortex. I wish it were this simple, but it turns out the auditory system is connected to many different parts of the brain. One part of the brain it's connected to is the hippocampus. The hippocampus, we know that's very important for memory, also involved in spatial location, locating where we are in space. Another part of the brain that receives auditory information is the amygdala. This is an emotional processing part of the brain. We're going to look at that later on today. There's another part of the brain down in the brainstem in the midbrain called the reticular formation. When a loud sound comes in, we get very aroused. That area of the brain gets activated. And then surprisingly, one area that I never expected to be involved would be the cerebellum. If you look at the parts of the cerebellum, the parafloccular lobe in particular seems to get activated by sound stimulation. So we're going to look at all of these areas later today. So I'm going to go back a little bit in time. Tinnitus and probably hyperacusis have traditionally been thought to be disorders of the inner ear. And the reason for that is when you have some damage to the inner ear, you usually hear the tinnitus in the damaged ear. So the idea is that because you hear the tinnitus in your damaged ear, the tinnitus generator must be in the damaged ear. And that was the traditional hypothesis for many, many years. It was thought that people that had tinnitus had hyperactivity in the auditory nerve. And one of the important pieces of clinical information that helped to change our thinking about this was patients that had acoustic neuroma. There'd be a tumor growing on the auditory and vestibular nerve. A surgeon would go in there, try to remove the tumor, and oftentimes would cut the auditory nerve, and the person would lose all their hearing. But the surprising thing is more than 50% of these people, after you cut the auditory nerve, still had the tinnitus. So what that tells you is that tinnitus can't be in the inner ear. If the tinnitus persists, it has to be somewhere in the brain. So in the 90s, we started to do some imaging studies, which I will not discuss today. Just mention them briefly. And these positron emission tomography studies were done on patients that could modulate their tinnitus. They could turn their tinnitus on and off by clenching their jaw. And what happened when they turned the tinnitus up or down, you could see hyperactivity emerging in the auditory cortex on one side, the medial geniculate body, and also in the hippocampus. So that was good evidence that basically tinnitus originates somewhere in the central nervous system. And what we think happens is when you basically have damage to your inner ear or your auditory nerve, this triggers some abnormal plastic changes in the brain. We think of tinnitus as analogous to something like phantom limb pain. Cut off a leg or a limb, and you feel the pain in a missing limb. Well, something like that we think is going on in the auditory systems. One of the things that happens when you lose the information from the inner ear, the central auditory system tries to compensate for this. And how it does this is it turns up its volume control. You have this weak signal coming from the cochlea, and what happens as the brain turns up its gain, you hear better, but one of the negative side effects for this is it may turn up the gain too much and you get something like
Professor,
tinnitus.
sorry for interruption. For the audience, turn off your mic. I don't know. For the audience, please get sure your mics are off.
Okay.
We appreciate if you just turn your mics off, please. Okay, Professor, I think now you can.
So we think the brain has something like a hearing aid in it that turns up its volume control, but when it turns it up too much, we run into tinnitus. So one of the things we wanted to do is develop some animal models of tinnitus. And one of the first steps you need to do is figure out a way of having an animal like a rat tell you when they have tinnitus. So one of the techniques we developed is called SIPAC, scheduled induced polydipsia. This is where you drink even though you're not thirsty. And the way we get animals to drink even though they're not thirsty, we food deprive them, and then we give them a food pellet once per minute. And while we're waiting for the next food pellet to come, they start to drink. So they're not thirsty, but they're drinking anyhow. Then we take that drinking behavior and we put it under stimulus control. We tell the rat, you can only take a drink when the environment is quiet. If there's any sound in the environment, you're going to get a shock on the foot. So the animals learn they can only drink water when it's quiet. If there's any sound in the environment, they have to stop drinking, otherwise they'll get a foot shock. So these are some data from rats that are well trained. On the right side over here, we now look at the number of licks the animals are making for water. We have 30-second intervals, and we play them. They can either be quiet intervals, which are the ones in red. And when they're quiet, you can see the animals lick a lot. And when there's sound in the 30-second intervals, the animals never lick. So they never lick when there's sound. They always lick when it's quiet. So we train them up very well on this. So one of the ways you can induce tinnitus very reliably is by giving animals and humans a high dose of aspirin. Aspirin used to be used to treat people with severe rheumatoid arthritis. And your physician would tell you, keep increasing your dose of Bayer aspirin until you get tinnitus. And then when the tinnitus comes on, just lower the dose a little bit. That's the correct dose to treat your rheumatoid arthritis. So that's well known in the literature. So we gave rats a high dose of aspirin, which is the active ingredient in, or salicylate, which is the active ingredient in aspirin. Here we give a dose of 50 milligrams per kilogram. The animal still licks when it's quiet environment, never licks when there's sound. We give 100 milligrams. The animal continues to lick in quiet, never licks when there's a sound. But when we give the dose of 150 milligrams or 250 milligrams, we give that dose. On the day that we give that dose, the animal stops drinking for water. And the reason he stops drinking is he hearing the phantom sound. So the phantom sound occurs during the quiet intervals and the animal never licks. We take the drug away and the licking comes back. We go to higher dose, 250 milligrams, never licks, take the drug away, and he starts licking again. So this is a dose response function for sodium salicylate. You can look at the licks per session. When there's sound in the environment, the animals never lick. On the quiet trials, when we give the dose either 0, 50, or 100 milligrams per kilogram of sodium salicylate, they always lick when there's quiet. But when the dose gets up to 150, 250, or 350, they stop licking. So this tells you that these animals are experiencing tinnitus only with this high dose of salicylate. So this is a magic number. 150 milligrams per kilogram or higher will induce tinnitus very reliably. One of the things we did a few years ago, we wondered if you gave animals a high dose of salicylate, would they get hyperacusis? So one of the ways you can measure hyperacusis or measure loudness in humans or animals is to measure what are called reaction time versus intensity functions. So the louder a sound is, the more quickly you respond to it. When my wife yells at me, I respond very quickly, and when she speaks quietly, I respond very slowly. So this has been done extensively in humans and in animals, and we applied this technique to study hyperacusis. So this shows you the reaction time for a group of rats. Baseline testing are the black lines over here. As we increase the sound level, the reaction time for the rat to get a food pellet goes down. So you can see a nice orderly progression. We treat the rat then with saline, which is a control condition. Saline doesn't do anything to the reaction time. But we give the rat something like 200 to 300 milligrams per kilogram of sodium salicylate, you can see a dramatic change in the reaction time intensity functions. At low sound levels, the reaction times become longer than normal. And the reason they become longer than normal is salicylate not only gives you tinnitus and hyperacusis, it also gives you about a 20 dB hearing loss. So these sounds would be just barely above threshold. As the sound level goes up, you can see the reaction times quickly decrease, and then they actually become much shorter than normal. Down in this range where you see reaction times that are much shorter than normal, we think the animals have hyperacusis. You take the drug away, and the reaction times go back to normal. We also use this technique to basically study hyperacusis induced by noise. So these are some animals that we noise expose at 102 dB. We expose them to a high frequency noise, 16 to 20 kilohertz, and we expose them for 6 weeks. We measured their reaction time intensity functions during the noise exposure. We didn't see too much change, but interestingly, about a week or two after they were exposed, we saw dramatic changes in the reaction time intensity functions. These are the reaction time intensity functions at 20,000 hertz. At 20,000 hertz, the animals have about a 50 to 60 dB hearing loss. And these were the reaction time intensity functions in the rats before we noise exposed them. And these were the reaction times after we noise exposed them. So because they have a large hearing loss, you don't get a response at these low sound levels. They only respond at around 60 to 70 dB. And here you see a rapid reduction in the reaction times, and they catch up to the normal level. This looks very much like loudness recruitment that you'd get in normal hearing or in hearing impaired subjects, where you get loudness recruitment. 16 kilohertz is a frequency right at the border of the hearing loss. The animals have a little bit of a hearing loss over here, about 15 decibels. These were the reaction times before we gave the drug, nice orderly decrease. And these were the reaction times after they were noise exposed. So you can see the reaction times at 40 dB are a little bit longer than normal because there's a small hearing loss over here. But as we increase the sound level, the reaction times quickly catch up and they become shorter than normal. And so you can see over in this region, Shorter than normal reaction times mean the rats have hyperacusis. So this is really a very useful tool. We wanted to develop one other tool for looking at hyperacusis. And this is kind of a very clever technique developed by one of my postdocs, Dr. Manohar. It's called an active sound avoidance hyperacusis model. This is a very clever technique. Excuse me. If you take a rat and put it in a bright, open environment, they don't like being there because they think a predator, like an owl, will come and catch them and have them for supper. So if you give them a choice to being in a dark space or a bright, open enclosure, they'll want to stay in the dark enclosure. So we take rats, we put them in this arena that has a dark enclosure and a bright, open space, and the rats always choose to be in the dark space. In the dark space, we put a loudspeaker, and we use that loudspeaker to turn up the volume and drive if it's uncomfortable, we think we'll drive the rat out of here into the open space. So let's see what happens. So these were some rats. These were the baseline testing conditions. In the quiet environment, when it's quiet inside the dark box, the rats spend almost 100% of the time there. If we turn the sound up to 60 dB, the sound will drive the rat out a little bit. And if we go up to 90 dB, it drives them out a little bit more. They only spend about 80% of the time in the dark. What we did to these rats after we tested them, the blue data over here, we exposed them to this high frequency noise that we showed earlier could induce hyperacusis, and we tested them several weeks later. These animals have about a 60 dB high frequency hearing loss, and they have normal hearing in the low frequencies, 2 to 12 kilohertz. We played a low frequency sound, 2 to 8 kilohertz, at 60 and 90 dB, and you can see this is after they had the hearing loss. They still prefer the dark box when it's quiet in the dark box. But as you turn the sound level up, the low frequency sounds in the dark box, you can see the animals want to get out of the dark box and leave. So the difference between the blue lines and the red lines over here is after the noise exposure, these animals find the sounds more aversive. They don't want to be there. Okay, so I've told you some of the ways you can train an animal to tell you they have tinnitus or hyperacusis. What we wanted to do afterwards is figure out what's going on in the brain to explain these behavioral phenotypes. So one of the things we do, we have electrodes. They're multi-channel electrodes. We can either record the single unit spike discharges, or we can record the local field potentials that come from specific regions of the brain. We'll place these electrodes in very specific locations. So the first place we started was in the cochlea. We are going to look at all the data that we obtained with aspirin, high doses of sodium salicylate. So here's the input, what's called the input-output function from the cochlea. We put an electrode on the cochlea, we measure the compound action potential. This is the mean amplitude as we start increasing the sound level. You can see the intensity going up, the response going up as we increase the intensity. And then after we give the sodium salicylate 2 hours later, you see that the response goes up as we increase intensity, but the responses are much, much smaller. Two things to note about this function. The responses at high levels are greatly reduced. They used to be about 110 microvolts. Now they're down around 40 microvolts. The other thing is this function is shifted over to the right about 25 dB. This lateral shift is, we think of that as the threshold shift, and this is the reduction in suprathreshold activity. So over on the right side over here, we show you how much this response is reduced at high sound levels. You'll notice on this scale on the left over here, all of these are negative values. It means all the responses are reduced at high levels. So if you measure the output of the cochlea at different frequencies, you see the response is reduced by as much as 60 to 70%. So the neural output of the cochlea, when you take a high dose of aspirin, is greatly reduced. Let's take our electrode now and put it in to the cochlear nucleus. The auditory nerve relays its information into the next part of the auditory brain, the cochlear nucleus. This is the cochlear nucleus input-output function. It shows you the magnitude of the response in the cochlear nucleus. The black lines show you the data before we gave the drug. You see a nice robust response at high sound levels. After we give the salicylate, the function shifted to the right, and as high levels, the response grows a lot. It's still reduced, but not as much as in the cochlea. It's only reduced about 25 to 35%. Let's go to the inferior colliculus, the next relay station in the midbrain. This is the response from the inferior colliculus. This is the response before we gave the drug. After we gave sodium salicylate, the function is shifted over about 20 dB. That's the hearing loss. And then you see the response grow very rapidly. And at high sound levels is actually a little bit larger than normal. Looking over here at the right, at the responses at high levels, you can see the responses are actually almost normal, and in fact, slightly greater than normal. Let's go up to the auditory cortex. The black lines show you the response from the auditory cortex before we gave the drug. You can see the response increases. The red lines show you the data after we give the salicylate. The function is shifted over about 20, 25 dB. Once we get above threshold, the responses grow very rapidly. And over here, you can see the responses are almost 2 to 3 times larger, quite a bit larger than normal. This data over here is from a whole group of animals, shows you the responses at suprathreshold levels. And the thing to note over here, the responses are anywhere from 25 to 100% greater. So the inner ear signal is very weak. As you go up the auditory pathway, it increases. So this is the response at the cochlea, greatly reduced. Cochlear nucleus reduced a slight amount. Inferior colliculus almost back to normal. Auditory cortex, everything is higher than normal, much stronger than normal. Remember when we started, I told you I would take you to some other parts of the brain. This is the lateral amygdala. We'd never done any work in this until a few years ago. This shows you the local field potential in the lateral amygdala. So this is time on the x-axis. This is the response amplitude. This is to 100 dB tone burst. You see a nice response before we give the drug salicylate. And a few hours after we give the drug, you can see the amygdala response is much larger than normal. This is the input-output function from the amygdala. The black line is before we give the drug. And 2 hours after we give the drug, you can see the function is shifted over to the right. That's the hearing loss we think that begins in the cochlea. But at suprathreshold levels, the response is larger than normal. So salicylate's not only affecting the auditory system, it's affecting parts of the brain that are involved in emotion. This is a very interesting experiment. What we did over here is we took salicylate and rather give it to the whole animal, we had put a cannula in and we put salicylate just into the amygdala. So the salicylate's being given locally to one part of the brain, and then we put a recording electrode into the auditory cortex. So this is the response from the auditory cortex. The black line is before we give the drug. The red line is after we give the drug. And you can see after we put the salicylate into the amygdala, the cortex response gets bigger. Now this is the really interesting and part of the result. The black line shows you the response from the auditory cortex before we gave the drug. You can see the nice growth in the input-output function from the cortex. After we infuse the drug into the amygdala, you see that the responses in the cortex get bigger, but the most striking and important result over here, when we apply salicylate only to the amygdala, it has no effect on threshold. So the threshold shift we saw earlier, we think it's because the salicylate is affecting the cochlea. We apply salicylate locally to the amygdala, it doesn't affect threshold. It only affects the suprathreshold responses. Why do we think salicylate is such a good way of inducing tinnitus and hyperacusis? Well, one of the reasons we think it might be is because it actually has an effect on some of your stress systems. So many of you that have worked with tinnitus patients know they're highly stressed, they're depressed, they have high anxiety scores. So one of the things we did after we give salicylate, we measured in the blood, took a blood sample, and we measured the corticosteroid stress hormone levels. So these are the stress hormone levels on the y-axis, and this is the salicylate dose. Remember, I told you the magic salicylate dose was 150 milligrams per kilogram. If you give a rat 50 milligrams per kilogram of sodium salicylate, you don't see any change in the stress hormones. But as soon as you get up to 150, you see a surge in the stress hormones. And as you go up to 250 milligrams, they go way up. So salicylate may be really good at inducing tinnitus and hyperacusis, not only because it gives you a hearing loss, because it has effects on other parts of your auditory brain. So one of the things we wanted to do is look at other parts of the central nervous system. So I have some colleagues that I work with in Nanjing, China, and they have access to an fMRI scanner where you can test animals like a rat. And one of the things we measured is a measurement called ALF. It's called the Amplitude of Low Frequency Fluctuations. This is the ALF. These are the bold responses that you can measure in the brain. This is the fluctuation of the metabolic activity of the brain. And this is the task that's going on over here. You can see when the task occurs, you can see these fluctuations go up. And this is data from a human. I'm going to show you data now just like this from a rat. So we took some rats, we gave them a high dose of salicylate, and we measured the ALF response, and we looked in different parts of the brain to see where the ALF response would go up. So these red spots over here show you places in the brain where the brain activity increased. PFL stands for the parafloccular lobe of the cerebellum. RN stands for the reticular nucleus, part of the reticular formation. IC is the inferior colliculus. VCX is the visual cortex. ACX is the auditory cortex. MGB is the medial geniculate. So we saw activity in all these areas. We also saw some areas where the activity decreased, namely in the hippocampus. So this is a synopsis of what went on in those studies. We saw 3 parts of the auditory brain where activity went up above its normal level: the auditory cortex, inferior colliculus, medial geniculate. This fits in perfectly with our electrophysiological data. We also saw some increases in other sensory areas, somatosensory cortex, visual cortex, superior colliculus. We saw increases in the amygdala, similar to what we saw with our electrophysiology. We saw increases in the reticular formation, this arousal area. We saw increases in the cerebellum, and we saw decreases in the hippocampus and the caudate putamen. So this was very nice. Most of these data agree perfectly with our electrophysiology data. And we have additional electrophysiology data that confirm many of these trends. There's another technique you can use when you do functional imaging. It's called the functional connectivity. And the way functional connectivity, it's like dancing. You can see the different parts of the brain that are working together. So these green and orange lines over here show you the bold response from the motor areas of a human. And you can see the motor area in the left and right cortex are synchronized with one another. There's a high degree of correlation. The correlation is about 0.84. In the bottom graph over here, we're looking at the correlation between the bold signal in the motor cortex with the visual cortex. And here the correlation is very low. It's only about 0.06. So what we did with our salicylate model is we looked at the parts of the brain that were correlated with one another. Well, one of the ways you can do this, you can say, I'm going to look in the auditory cortex and I'm going to see what other parts of the brain are correlated with the auditory cortex when I give salicylate, where there's an increase in correlation. You can see there's a big increase in the cerebellum, the medial geniculate, the amygdala, and the inferior colliculus over here. You can go back and you can now put your, look at the correlation between the medial geniculate body. You can see where's the medial geniculate body correlated with. And it's correlated with the hippocampus and the auditory cortex. You can put your assessment area in the inferior colliculus and ask what's working with the hippocampus, what's working with the inferior colliculus. You can see that's the inferior colliculus and the medial geniculate body. So this graph shows you all the areas where we see an increase in what's called functional connectivity. The auditory cortex, interestingly, connects to all these areas. It increases its connectivity to the medial geniculate, inferior colliculus, amygdala, reticular formation, paraflocculus lobe of the cerebellum. The medial geniculate body only increases its functional connectivity with the auditory cortex and the hippocampus. Likewise, the inferior colliculus only increases its functional connectivity with the medial geniculate and hippocampus. So this network, if you look at the network analysis, what you see is there's an auditory network consisting of the Aazh, auditory cortex, medial geniculate, and inferior colliculus. It all gets hyperactive and it becomes more connected with one another. We also see that the amygdala gets linked into this network. The emotional center of the brain now becomes more attached to the auditory network. The hippocampus, which is involved in spatial navigation and memory of sound, that also becomes linked in with the parts of the auditory system. The reticular formation, this arousal area that gets you aroused when you hear a sound that you don't like, that also gets turned on. And the cerebellum also gets linked in, specific parts of the cerebellum. So we have this network. We think that tinnitus and hyperacusis is not just activity in one part of the brain, but rather this global change in activity in many of these different areas over here. So usually people call me up, want to know what's the treatment for tinnitus. And actually there are some treatments. Many of them I'm sure you audiologists use. Hearing aids are quite effective. If you can get a patient with tinnitus that needs a hearing aid to wear it, that often suppresses the tinnitus and hyperacusis. If they don't need a hearing aid, a sound generator often works along with counseling and other techniques. And people that have cochlear implants, about 70 to 80% of them that have tinnitus, when you turn their implants on, their tinnitus is suppressed. So all of these, the idea is when you put sound back into the auditory pathway, it turns down the gain of the auditory pathway, and oftentimes the tinnitus is suppressed. In the future, we're looking at ways to developing new pharmaceuticals to treat tinnitus. We had one drug that we used in one of our experimental models, a potassium channel modulator that worked very well, transcranial magnetic stimulation, and brain electrical stimulation. And I'm going to stop here, and these are many of our collaborators and our funding sources. I'd be happy to take any questions.
Thank you, Dr. Salvi. I'm always amazed by the amount of information that you share with your audience. There are a couple of questions. I'm going to start with one of them that was sent to us. Then Dr. Alfarghal also has a question that we will mention it. One of the audience has asked that in the absence of normative data for frequencies beyond 8 kilohertz, at least in human, how can you be sure that the rats have hearing loss that can quantify for 15 to 20 dB loss? I'm sure that he's asking about your electrophysiological method.
Yeah. 2 ways. One of them, I didn't show you the data, but you can take a rat and do an audiogram on them by behaviorally training them. And so the noise-induced hearing loss, we actually measured the animals' hearing thresholds by behavioral techniques. So we know they have about a 50 to 60 dB hearing loss. We do the same thing with Solista. We can measure the behavioral hearing loss. The electrophysiological techniques, you just figure out what the sound level is, and you can get an electrophysiological response when they're normal, and then after you give the drug or after you give a noise-induced hearing loss, noise exposure. So they're pretty standard techniques.
Excellent, Dr. Salvi. So there are some questions coming about the clinical aspects of the tinnitus therapy that I'm going to postpone them to other lectures. And another question is from Dr. Moahamd. Go ahead, Alfarghal, please.
Professor Salvi, thank you for the great lecture. My question is that humans, they have higher intellectual functions. They have higher cognition, very sophisticated emotions. So do animal models really explain the whole pathophysiology of tinnitus? I do expect there is difference between animals and the human because of the difference in cognitive emotions and sophisticated intellectual functions. So how can you explain this, Professor?
That's a very good question. You know, one of the things I think is quite important is attention. And if you're a tinnitus patient and you think the tinnitus might be lead to more severe outcome, like more hearing loss, you're going to really attend to it. So oftentimes people get into this loop. They get tinnitus, they start attending to it, and the more they tend to it, the more bothersome the tinnitus gets. So there are other techniques like cognitive behavioral therapy that try to and other techniques, clinical techniques, where you try to get patients not to listen to or focus to their tinnitus. So there's definitely an attentional and a cognitive component to this. We have not done any work in animal models with that. It's difficult enough just to do the audiometric testing. We haven't gotten them to take any paper and pencil tests with us. Yes.
Thank you, Dr. Salvi. We have time for one more question that I'm going to share it with you. There are some other questions that can be answered on a different time. But the question that one of the audience has presented in here is that how we explain tinnitus in people with normal hearing. So are your studies can support? Go ahead, please.
So that's, again, an excellent question. I have many people who will call me up, 60, 70-year-olds, and they say, Dr. Salvi, I have normal hearing. I said, you have normal hearing on a clinical audiogram. And they oftentimes fail to test your hearing between 8 and 20 kilohertz. Most of these people, when you take them in, even young people, and take them in and you test that on ultra high frequencies, they oftentimes show up to have a hearing loss. And just because your hearing is within the so-called normal range, 20 dB HL or 25 dB HL, that doesn't mean your hearing is normal. Normal hearing is really 0. So that's two possible explanations. A second one is there's a phenomenon called hidden hearing loss that people at Harvard University like Sharon Kujawa and Lieberman have promoted. The idea that you can have damage to the afferent auditory nerve synapses and have no audiometric threshold shift. We actually probably have one of the best animal models of hidden hearing loss. We would give chinchillas a dose of carboplatin, which would wipe out as much as 60, 70, 80, 90% of the inner hair cells. And if we tested the animals' behavioral thresholds, its behavioral thresholds would be completely normal as long as it had all its outer hair cells. So you can have a normal audiogram with tremendous damage to the inner hair cells or the afferent neurons that contact the inner hair cells, as long as you have intact outer hair cells.
Excellent. Thank you, Dr. Salvi. Because of the time limitations that we have, I'm going to ask our next speaker to join us. And if we have time at the end of the conference workshop, we'll get back to some of those questions that are being proposed in here. So thanks, Dr. Salvi. We really appreciate it. And so, Dr. Alfarghal, are you online? Okay.
I'll just share the screen.
All right, I have had the pleasure of having Dr. Alfarghal actually is one of my classes. He was in my genetic class, one of the stars in the class. So he did wonderful. He got an A from me. So that's wonderful. And we are gonna go and listen to you for around 10-15 minutes. Dr. Moahamd, go ahead, please.
15 minutes, Professor. So it's a great honor, really, to be with my professor and all the other great professors. So just you can see in this slide where I do work in King Abdulaziz Medical City. It's a military hospital, tertiary care military hospital. So that's why we have a lot of tinnitus patients. Then you will find the logo of our Facebook group with now approaching 22,000 of professionals, despite it's a closed group. Then our future plans, which coming to become true in a couple of days, we decided to establish an online academy for audiovestibular training. And our first project will be the online vestibular diploma, but we have a plan to extend our activities to other scopes in the field. So I just share with you some of, I have been working with tinnitus patients for almost 15 years. I learned a lot. I went to many countries to learn. So just I share with you some of the journey. So it's first, I start with you with this video. I hope that you can hear the sound. This is a tinnitus simulation by Johnson Hazel, one of the pioneers in the tinnitus retraining therapy. I think he started with Professor Jester Boff. So I got this video 15 years back, and I have been using in counseling the patients. So in this simulation, they put different kinds of sensory neural tinnitus, somato sounds, clicks of myoclonus, pulsatile tinnitus, and later on I can share with you the audio file. So just listen to the different sounds. So just to save the time, let's go on. So we know that is around 20%. Professor Salvi mentioned 12%, but in different studies, it's up to 25% of the general population, they can experience tinnitus, but only in 2 to 5% of those cases, it's significant and needs medical services. And 80% of tinnitus patients, they habituate naturally. And tinnitus, we consider it clinically significant if it lasts more than 5 minutes, because I got many referrals for transient tinnitus for seconds, and sometimes other clinicians or other medical specialists, they don't ask the duration of tinnitus, just any kind of tinnitus. No, it should be at least lasting 5 minutes to be considered clinically significant. So quantifying tinnitus problem is the gate for proper management. In 2008 and 2002, when I was doing my master's at Ain Shams University in audiovestibular medicine, so I got some assignment and I created a protocol to for approach for tinnitus, and it was focused to identify the cause or etiology of tinnitus. And I was very enthusiastic about it, but it already has a great limitation because it was based on the medical model. So the medical model was in the core of developing this protocol. So we look for a deficit. We look for anatomical, structural, or physiological dysfunction. And if we can identify, we can treat. Unfortunately, at that time, I wasn't. Yeah. So the medical model was working very well in this protocol for the rhythmic or pulsatile or somato sounds or the objective tinnitus, because usually they are medical problems, and identifying them is a very good approach, and it worked well. But the limitation of this protocol was that we only looked for physiological or anatomical proof of auditory pathway dysfunction, looking for evidence for outer, middle, or inner ear dysfunction, outer or inner hair cells dysfunction, auditory nerve afferent or efferent dysfunction, brainstem or brain dysfunction. So we do all the extensive audiological measures, but I have missed to focus on questionnaires, on the mental, psychological, and emotional aspects of tinnitus in this protocol. Therefore, in this protocol, we call the rhythmic and non-rhythmic tinnitus after looking for objective or pulsatile. So we choose to put rhythmic, but lately, I guess the term somato sounds proposed by Jasterboff is a very good name for all these somato sounds. So it's used to indicate the perception that is generated within a body, typically by structures in and adjacent to the ear. We included this in this protocol. That is, we have to ask the patient description if there is a relation of the pulsatile tinnitus to the heartbeats, or for the somato sounds to heartbeats, or it's clicking or venous hum, or does it change with head position or relation to the respiration. And we do a clinical exam like a light neck compression or head rotation. We see the effect if that somato sounds or the pulsations will disappear completely or just diminish or just no change. So this is tell you it's arterial venous or arteriovenous malformation. Then also we do look for the effect of clenching or relaxation of the jaw joint. This is specifically for the tensor tympani myoclonus. So we see if it's provoked by clenching the mouth or it disappears with relaxation or no change. So if it provoked with clenching and disappears with relaxation of the mouth, that's most likely a tensor tympani myoclonus. We do auscultation of the ear canal, orbit, occipital region, pre-auricular, and the parotid region, and auscultation of the neck, and the recording from the mouth, because like tensor palatini myoclonus, it's better to be recorded from the mouth. And sometimes we use the clip stethoscope, which usually the audiologist use for hearing aid check, that can be used to record or to hear better the pulsations. And many of the clinicians, they record using the iPhone, and I will share you one audio file done by one of our colleagues. So always the workup for the somato sounds is just to do microscopic examination of the ear, palatal examination, audiometry, tympanometry, high gain tympanometry, where we use the reflex decay mode without sound stimulus, just to record with high sensitivity any perturbation of the tympanic membrane. And we did a lot of work in recording this high gain tympanometry in cases of pulsatile tinnitus. We do CBC, hemoglobin, and the thyroid profile, because sometimes those conditions, they cause pulsatile tinnitus. We do fundus examination to exclude the increased intracranial tension. We do CT temporal bone for the paraganglionoma. We do temporomandibular joint examination, cardiovascular examination, neurological evaluation, and the main goal of the examination to exclude underlying serious causes. So I share with you here just one of our videos for a large glomus jugular. And interestingly, this patient does not have pulsatile tinnitus because the patient has severe sensory neural hearing loss. So we observe it in few cases. If the patient developed a severe degree of sensory neural hearing loss, they no more hear the pulsations. So and you can see here the tumor is bulging in the tympanic membrane. It's bulging in the tympanic membrane. It was a huge glomus. So let's, yeah, this is one of my colleague, Dr. Mahmoud Mahrous, recorded this pulsatile tinnitus or clicking tinnitus due to a palatal myoclonus from one of his patients. So just you can hear. You can hear the clicking. Okay, so yeah, I want to share you one of the interesting cases from our clinic. A patient who has a cerebellar stroke, and she developed clicking tinnitus because of palatal tremors. So I share our colleagues at the speech swallowing unit. They just recorded very nice video for the palatal myoclonus or the palatal tremors. You can see the tremors of the palate. And this is how it looks like. We have a lot of cases, so we have an interesting database how to record these pulsations using the tympanometry. We presented it in one of the international conferences. So as you see, if you count, you will find like 15 beats or 15 peaks in 15 seconds, which is very approximately the same like the human pulse. Recently, we got a system, another system for, actually it's a design, it's an Italian system. It's designed to record the electrical stability reflex for the cochlear implant programming. But I adopted it and I used it to record one of the pulsations. So I have a patient who has a very narrow carotid cochlear cleft. So as you see here, the pulsations, and if you count, you find them, they approximate the heart rates. So it was very clear, and we take the other ear as a control. He has a unilateral pulsatile tinnitus, and the narrowing of the carotid cochlear cleft was confirmed by the CT temporal. So we have seen along this clinical experience a lot of interesting cases, and one of interesting cases I have seen is gaze evoked tinnitus. And from the presentation of Professor Salvi, I now have a clear explanation, because the network for tinnitus is connected to the cerebellum. So this could explain the gaze evoked tinnitus. So we have one case of gaze evoked tinnitus. We have cochlear carotid cleft narrowing. We have tens of glomus cases with different presentation, pulsatile tinnitus, no tinnitus at all, or somatosensory tinnitus. We have interesting case of temporomandibular joint herniated into the external ear canal. Yeah, so in 2006, I got that hard copy of Tinnitus Retraining. I read 10 times. I got fascinated and impressed with the work, and because it has some philosophy and very nice quotes, and I really got in love with the Tinnitus Retraining therapy. And I have been always using the candle for counseling. That's the candle in the dark become very prominent, and something like very important. But if you turn the light around the candle, it just becomes very faint and not noticeable. So I start my first experience in tinnitus retraining therapy in 2006, and we have been using, I was working in Medina in a private hospital, and I used the counseling. I become very advocate to the sound therapy, and we use a model of that is every home has a refrigerator, but nobody is paying attention to the sound of the refrigerator, and this is the natural habituation of the neutral sounds. And of course, we have been focusing on the mixing ratio and in the sound therapy. One of the mistakes I did, or the lack of good training at the time, that we have focused more on the sound therapy than the counseling. So that's why we have failure cases. And it was clear, the research revealed later on, and I'm sharing here the paper of Professor Richard Taylor, one of my professor, that is one premise of retraining therapy is incorrect. A focus on the mixing point. Masking is not required for habituation. So our thoughts have changed over time. And let's also share, this is a great publication by Professor Hashir, our guest today, which has impact on my practice personally. That is, the results suggest the benefit may be obtained from a substantially simplified form of tinnitus retraining therapy. So the long and a little bit complicated and strict protocols proposed by Professor Paul Jesterboff, it's not a mandatory must to achieve a good results. And our clinical experience, I'm a frontline clinician. I'm not a very good researcher, but I'm a very passionate and active frontline clinicians. So one more of the points I want to share also, that is the pitch matching, loudness matching, minimal masking, level resolution. It was very focused during my undergraduate training, and many audiologists, they are fan of this. They are good, but they don't have much impact on the management plan. You can do very well without doing them. The only advantage we believe in them, that is they let the patient feel that you share his feeling, that is not a mad or insane, that you can feel his tinnitus, you can describe his tinnitus, you know what he's feeling. So this is very good point for using them, but they don't have much impact in the sound therapy or in the management generally. Then later I went to improving my skills in counseling. I started getting books written for the patient counseling, one of them written by a Canadian audiologist who suffered tinnitus a long time, and she put her personal experience with audiological experience. Then the other book written by Professor David Bagley as a counseling for the patient. I got also the book written by Richard Taylor, the Consumer Handbook in Tinnitus. This is written for the patient, but it's excellent for the clinician, because most of us, they don't honestly know what to say to the patient. Then lately, I got this great book by Professor James Henry and his colleagues. This is about the counseling guide about the tinnitus retraining therapy. I translated that book. It took me 6 months to translate this counseling book, and it came in the next slides. And definitely in this journey, I refined. I looked to the Arabic versions of Tinnitus Handicap inventory, which there is some agreement that it's a best questionnaire and very valid and very sensitive. So 2 versions I found of Arabic, I didn't find them fit to my population or my patients. So I refined the translation, and we validated it in our institute, but we didn't publish, but we have been using it for years, and we have a lot of database for this one. So the tinnitus handicap inventory is very sensitive tool to quantify the severity of tinnitus of your patient, because this is the main gate, or to decide what kind of treatment they need. So if like you got a score below 24 or something, most likely all what they need just counseling. So this is a very critical and very important point for clinicians. We sometimes use a visual analog scale for tinnitus. So just patient, we give him a scale from 0 to 100, just rank your tinnitus today. And because of hyperacusis, should be assessed in all tinnitus patients, because as Professor Salvi mentioned, that about 40% of tinnitus patients, they have hyperacusis. And if there is hyperacusis, you have to treat the hyperacusis first. So that's why we refined the Arabic version translated by Professor Shabana in 2011. We refined the translation to fit our population. I do work in Saudi Arabia, so there is some dialect differences between the Egyptian Arabic and Saudi Arabic. So I just refined it and we validated and we use it. The counseling book, it took me 6 months to professionally translate, and I put it in a program. I got permission from the author, and we called it Tarwid al-Tanin in Arabic. So, and we have been using it. We didn't publish the Arabic book, but we have been using the counseling material for years, and really it's a great book and a great examples for counseling. And over those years, really, my skills become completely different. So this is example of what kind of counseling we use. We use example of a candle in the darkness and light. We use a refrigerator. We use that as some people living near the airport with too much noise or on the highway, but because of that is this kind of sound is just labeled as a neutral sound, they don't pay attention to it. We use the snake model. We don't have time to explain, but it is a very nice model how the negative emotional link to a sound can make its perception completely different than if there is a neutral emotion toward the sounds. Sound therapy for tinnitus, its aims is to decrease the contrast between the background neural activity and the tinnitus, and to interfere with the brain's ability to detect tinnitus signal, to reduce abnormal gain in the auditory system. Sound level should never induce annoyance or any kind of negative reaction. Sound shouldn't attract attention of the patients. And we use here in our clinic, we use the AC, because Saudi is a very hot or a very hot country. So most of the people, they have AC, and the AC can create noise. So we always advise those patients just turn on the AC during the sleep time where tinnitus becomes more annoying. And we use a lot of smartphone application. Some of them, they are very good, not all the same. So we have some preferred applications. And we use definitely the combined hearing aid, which can do amplification and do noise generation. I have the opportunity to work with one of the cochlear implant patients who already has been implanted just because of his intractable tinnitus. A 70 years old patient with Meniere's disease, with a right severe and left moderately severe sensory neural hearing loss. He's using hearing aid in the left side, and he implanted in the right ear just because of the tinnitus. He has intractable tinnitus. But after the implantation, he didn't improve a lot spontaneously. So he sought my opinion as a second opinion, and I applied my expertise in the tinnitus retraining therapy and sound therapy to improve his tinnitus with the cochlear implant. So the clinical tips I used, I little increased the T level of the cochlear implant. That sometimes create like a sound, background stimulation sound. So this is sometimes, and increase the audibility of the background noises. So this is helped to improve his tinnitus. And one more thing I did is to turn off the automatic noise reduction algorithm in the front sound processing in the processor. So by doing these two changes, really the patient got relieved from his tinnitus. So some concepts you learn from the sound therapy using the hearing aids, you can also apply for the cochlear implant users for tinnitus. So I increased the audibility of the soft sounds and the background noise, and I turned off all the automatic noise reduction algorithm. Yeah, one of, I get a lot of training, and I have been trained by Chester Boff, Richard Taylor, and I read tens of books, most of the books I read, and I follow a lot of publications from United States and the United Kingdom, New Zealand. So one of the good resources we use for our patient education, and we prepared some Arabic materials, is the one used by the National Health System in the United Kingdom. So about sleep hygiene, about relaxation, and about stress management, because those are key factors in the management of tinnitus. So stress reduction, relaxation, and sleep management or sleep hygiene are very critical and essential part in tinnitus management. So those are very good resources. And honestly speaking, I can say that lately, in just 1 hour session of counseling, usually I observe the face of the patient when he comes to the clinic with angry, upset, and sad face. And just after 30 minutes to 45 minutes of professional counseling, which needs training, I can see the smiling face and I can see the relief even from the first session. The last or take home message, I learned it during my learning journey about tinnitus, that relaxation is like bicycle riding. It's a skill which can be acquired at any age. Thank you very much. Thank you.
Thank you very much, Dr. Alfarghal, for your interesting presentation. Because of the lack of sufficient time, we would like to move on to our next presenter, who's Dr. Hashir Aazh, who's one of the rising stars in the field of tinnitus. He's an audiologist with a PhD and from the National Institute of Health Research, and he's a team leader for tinnitus and hyperacusis therapy, as well as the research and development lead at the audiology department at the Royal Surrey Hospital in Guildford, United Kingdom. It's my pleasure to invite Hashir Aazh to present his presentation. Go ahead, please. And please, everyone, mute your microphone. Some of you have iPhone, and I cannot mute as a host. So if you have an iPhone or a smartphone, please mute it. Thank
I managed, Professor.
Okay. Hello. Hi. Okay. I'm going to share my screen. Okay, so I hope you can hear me. So I'm going to start this presentation. Well, thank you very much for Professor Danesh and Dr.Alfarghal for inviting me on this program. And thank you for Dr. Salvi for the fantastic presentation, such as always. And thank you to all of you for taking time on your Saturday to come and learn about tinnitus and hyperacusis management and assessment and physiology of it, and research updates in general. And the topic of my presentation is on audiologist delivered cognitive behavior therapy for tinnitus and hyperacusis. And you have my email address here. So, so if you needed to contact me for questions, please feel free to do so. So let's start with some definitions. These are the definitions that I'm using for this presentation. So tinnitus is the perception of sound without any acoustic sound source. And people can perceive tinnitus to be in one of the ears or both ears or outside the head or inside the head. So it is not very uncommon that people, when they start hearing tinnitus for the very first time, they look around the house or the workplace and try to find out where is the sound source. So some people actually feel that the tinnitus is coming from outside, but some people feel it is from the right or the left ear, and some people from inside their head.
His accent is good.
And hyperacusis is intolerance of everyday sounds that causes significant distress and impairment in social, occupational, recreational, and other day-to-day activities. So people who have hyperacusis, they are not able to tolerate the day-to-day noises that other people can tolerate. And it can cause a lot of problem in their day-to-day life. Based on this definition, if somebody is just sensitive to sound, but it doesn't really cause any problem in their day-to-day life, that doesn't really classify as having hyperacusis. This study that I like to share with you, I had collaborators on this study, Professor Brian Moore from University of Cambridge and Professor Christina Bryant from University of Melbourne School of Psychology have supported me in this study. And these are my colleagues at the Royal Surrey County Hospital, where we have a tinnitus team. And these are the members of the tinnitus team, which every day I witness how compassionately and skillfully they help patients who suffer from tinnitus and hyperacusis. So I'd like to acknowledge their help and thank them for working so hard. The skills of cognitive behavior therapy for tinnitus management are specialized skills. So there are a wide range of counseling and other skills that the therapist needs to gain in order to be able to deliver cognitive behavior therapy, or CBT, focused on tinnitus management. So it is important to be able to assess the impact of the tinnitus on the person and also assess the contribution of hyperacusis element. Also, it is important to see what is the level of the distress that the patient is experiencing because of their tinnitus. And another critical thing is to be able to distinguish between the distress that the patient is experiencing, which is related to their tinnitus, or a distress that the patient is experiencing related to reasons other than tinnitus. Because it is possible that tinnitus causes a high level of anxiety in a person. And for that case, a CBT focused on tinnitus can be very helpful. But it also is possible a highly anxious person, perhaps a person with having an anxiety disorder of some sort, an obsessive compulsive disorder, post-traumatic stress, panic disorder, social phobia, to actually also develop tinnitus. So this person also will be very distressed, but the main source of the distress is not the tinnitus, is their underlying anxiety disorder. So it is very important to be able to distinguish what is the root cause of the distress that the patient is presenting. If it is directly linked to the tinnitus, then a CBT focused on tinnitus management would be ideal for this person. If the source of the anxiety and depressed mood is related to other underlying psychological disorders, then this person would benefit more from other forms of therapy, including CBT, but which are delivered by in mental health settings for their general anxiety disorder or mood disorder or whatever diagnosis they might have. So it is very important to be able to make that distinction. And then the other important things are to be able to motivate the person to actually engage in a CBT program, which is not aimed at eradicating tinnitus or distraction from tinnitus. It is aimed at acceptance of tinnitus. And so obviously people who have tinnitus very naturally, they do not want to hear this noise. There's nothing nice about it. And but what CBT can offer is not any change in tinnitus itself. It is about management of the tinnitus, which we will be talking about this. So how to motivate the patient to engage in a therapy like that also is very important. And also adjusting the therapy to the cognitive development level of your patient. For children, for special populations, it is another topic that needs a lot of work on, and exploring psychological comorbidities with tinnitus and hyperacusis, and how to screen for these, and what to do if you identify any of these, and making sure that the patients get the mental health treatments that they need from appropriate mental health professionals, if any of those, if they do suffer from any psychological disturbances. And also another important thing, to be able to explore suicidal and self-harm ideations in people who have tinnitus, and then help them, if they do, make sure that they see a psychiatrist or a psychologist, and immediately, so they can receive the support that they deserve. And also the last but not the least is to be able to deliver cognitive behavior therapy and all of its components to this patient. And I'm going to talk about and give you an overview of what are the different components of this type of intervention, and also the result of the evaluations that we did in our clinics about the outcome of delivering such therapy for patients. But to learn these skills of audiologists delivered cognitive behavior therapy for tinnitus and hyperacusis, the Tinnitus and Hyperacusis Therapy Masterclass, which you can see on this slide, and the website is tinnitustherapy.org.uk, is an annual course that I run in the UK, in London. And so, which, if you like to learn these skills, this is one way of achieving those skills. And in terms of research findings about tinnitus, hyperacusis, and specifically misophonia, there is this International Conference on Hyperacusis and Symposium of Misophonia and Sound Sensitivity, which is run in London every year. And unfortunately, this year is not going to happen. It was planned for 16th and 17th of July, but the conference has been postponed to 2021. So for this one also, you can look this up if you are interested in the latest developments in the field of hyperacusis and misophonia, and then look at this website on hyperacusisresearch.co.uk. So what is cognitive behavior therapy? Cognitive behavior therapy is based on Aaron Beck's cognitive theory of emotions. So based on his ideas, Aaron Beck is an American psychologist who is known as the father of CBT. And his idea was that the events that happens to us does not directly cause our emotional disturbances. But what is the main reason for the anger, annoyance, depression that we get as a response to the life events is what goes through our mind. So the thought process that goes through our mind is that link between the day-to-day events and our emotional reaction to those events. For example, if you if somebody tells you something and it makes you feel angry, according to Aaron Beck's cognitive theory, the reason that you got angry was not what they have told you. It is because of the interpretations in your mind about what they have said to you. So the thought that goes through your mind are the main reason for that emotional reaction that the person can have. And this idea is not something new. And at the same time, pretty much the same time as Aaron Beck, another American psychologist called Albert Ellis, he also developed a theory very consistent with this, and which was built on his rational and emotive therapy. So in fact, Albert Ellis is known as grandfather of CBT, of cognitive behavioral therapy, and Aaron Beck as the father. So, and also this idea that our thoughts causing our emotions is not new at all. Thousands of years ago, even Aristotle is quoted saying that emotional disturbances in man is not because of the things that happens to them, is because of their interpretation of those events. So the idea is not new, but Aaron Beck and Albert Ellis formulated it into a therapy that can be used for anxiety disorders and mood disorders. But CBT has been used not only for those disorders, but lots of other problems that people experience, and also for tinnitus. And for tinnitus, the idea with this to give patients a range of self-control strategies that they can change the way that they perceive and react to their tinnitus. So the key is to helping the patient to modify their reaction to their tinnitus, not necessarily doing anything to the tinnitus itself. And when people employ, so at the end of the treatment, tinnitus will still be present, but the management of it is enhanced. So when people employ the technique successfully, they will notice the tinnitus less. And that's what I will talk about that with you in the next few slides. So in order to do cognitive behavioral therapy, you need the first step would be to actually be able to explain what is the mechanism in which distress is produced in the person who hears tinnitus. And this process is called case conceptualization or formulation. And so what you see on this slide is describes for an example of a person who could have tinnitus. So tinnitus is the trigger, and the first thing that it creates some initial emotion and physical sensations. So this is like before the person starts thinking about it. There will be some sort of a sadness, being upset or anxiety, and then they could have some ear-related physical sensations or physical sensations in general. It is very common that people feel their ear is full of still some sort of a vibration in their ears, or feel tense in general. Some people report lots of different physical sensations or emotions that could go with this. And then they start developing some negative thoughts about their tinnitus and the impact of it on them. Like, if I focus on it, it will get louder. My silence is taken away. I have no control. This is quite a bothersome thought. It is harder to relax. I lost my peace and quiet. My hearing has been damaged. I cannot fully enjoy my life, and so on and so forth. These negative thoughts will lead to further negative emotions, such as feeling upset, angry, hopeless, and also some physical sensations, like feeling tense, restless, tearful. And all of these things that happen to this person, they have more negative evaluative thoughts about themselves about the future and life in general. And this is what is known as Aaron Beck's cognitive triad. So the negative thoughts that we have about ourselves, about the future, and about the world around us. So the thoughts like, I cannot cope, life is unfair, I am failing, and I will be isolated, so on and so forth. And these negative thoughts will feed back to that original sadness. The more sad the person gets, the more of these thoughts they develop. And the more of this thought, the more sadness. And this also will impact on the emotions of upsetness, anger, and hopelessness. And these will impact on the way that the person thinks. And those thoughts. So all of these parts of the model are cross-connected. So what we think impact on how we feel, and what we feel impact on the way that we think. For example, if you start thinking of some negative things, like things that are happening to some human beings in some poor parts of the world and in the wars, sickness, people dying, all of these things, animals, if you just think of these kind of thoughts, it does make you feel upset. So the thoughts can create emotion. And also, when you're upset, when you're angry, when you're very anxious, the way that you think is different than the way that you are relaxed. And that's why what they say, that do not make important decisions when you're angry, because the anger will distort your thinking. And it is not only the negative emotions that can impact on our thinking, even positive emotions can impact on our thinking. If you're too excited and happy, the way that you think, the things that you might agree with, are different compared when you are not. When you are in love, the way that you think is completely different. Some people say you do not think at all when you are in love. And so this is the cycle that is created when the person is perceiving tinnitus. Unfortunately, I can't get rid of this information at the top of my page, and but here they're gone now. So tinnitus is the trigger, and then this vicious cycle is developed. And this is what we say tinnitus distress. So this is when tinnitus is impacting on the person's life. So when the tinnitus is triggered, when the tinnitus triggers is this vicious cycle, then it becomes very important, and the person constantly notice their tinnitus. And this is, so what the aim of the treatment is to break this cycle. And how to break this cycle? There are parts of this model that are not under our direct control. For example, you can't ask your patient whenever they hear tinnitus, they feel happy, or don't get fullness in their ears, or don't get tense, or don't get angry. They can't directly control it. Most people can't directly control this. Some people can, like monks in Tibet, and that will take a lifetime of training to be able to control these type of physical sensations and emotions very directly. But most people can't really directly control their emotions or physical sensations. So, but what we can do is these two boxes, the thoughts, and more evaluative thoughts and the thoughts. So as human beings, we can change the way that we think. We can learn new things. And every time that you learn new things, the thought process changes. And so hence the cognitive therapy. So cognitive therapy's aim is to help the patient to explore these two boxes during those sessions that they receive the treatment, and then help them to modify them in a way that it doesn't really feed back into the whole model. So when these two boxes are modified, then the cycle stops, or the cycle collapses. That means they still hear the tinnitus, but the tinnitus is not triggering this cycle. That means that tinnitus is not causing the distress. This means they hear the tinnitus, but they are not affected by it. They can enjoy their life and they can do the activities that they need to do, even when they hear tinnitus. And when that happens, you send in this strong message to the brain that, look, this person is hearing tinnitus loud and clearly, but they can do whatever they need to do, and their mood is okay. So tinnitus cannot be an important thing. So it loses its significance and make it more likely to go to the background as opposed to be at the center of their attention. And this is how the ideas behind this specialized version of CBT for tinnitus and hyperacusis. Basically, in the CBT, you need to, the first thing that it needs to happen is creating this model for each individual person. So everybody's thought process, emotions, physical sensation would be different. And these are what you need to identify. And the same model applies to hyperacusis, but you have this on this slide presentation and also on the Masterclass website, which you can read them in your own time. But I don't focus on this because of the time constraints. So these are the people who were in this study. They received 6 sessions of CBT, and each session lasted for 1 hour, and there were face-to-face individual sessions in the clinic by an audiologist who has specialized in tinnitus management. So the first session, and it was about exploring what is the distress linked to tinnitus. Is it because of tinnitus? Is it because of other things? Second one, exploring what is the patient's reaction, developing that formulation of tinnitus, and then in working on the motivation, make sure that's motivated to engage in a therapy and either offer this treatment to them or discharge them. The second session, there are a wide range of different activities were derived, like designing of behavioral experiments where they have to do activities in order to test some of their negative thoughts, creating counter statements to the negative thoughts, which are more rational thoughts than the negative thoughts, and completing diaries for the thoughts and emotions, so on and so forth. So these were the typical activities included in the CBT sessions. The CBT can take between 6 to 20 sessions, but people who were in this study, they received 6 sessions of CBT. So the aim of the study was to evaluate the changes in the questionnaire score among people, scores assessing tinnitus, hyperacusis, insomnia, anxiety, and depression before and after CBT, to assess the perspective of patients who completed audiologist delivered CBT, and there were 31, about different aspects of the treatment, whether they felt the treatment was effective in helping them in managing their tinnitus, and whether the treatment was acceptable to them. This acceptability was quite an important thing for me, because people come to the audiology clinic or ENT clinic with a seemingly ear-related disorder of tinnitus, and so it may not be acceptable to them to do a psychological intervention in the form of CBT. So it was very important to us to know, was this treatment that we were offering acceptable to the patients who were experiencing this problem? And this slide shows the before and after tests, or before and after the scores on the questionnaires. So the first one is Tinnitus Handicap Inventory. The blue bars are pre-treatment, and the orange bars are after treatment. And so this one is for hyperacusis questionnaire by Khalfa, Insomnia Severity Index, anxiety, general anxiety, questionnaire, GAD-7, and PHQ-9, a questionnaire for depression, and then visual analog scale of tinnitus loudness. And so these were the scores of the patients, which, as you can see, have changed significantly after the treatment. This study was not a controlled trial, but there have been a lot of controlled trial and systematic reviews and meta-analysis on CBT for tinnitus. So we didn't really want to replicate those. This was more of a reflection of what was the benefit that the patients in our own local hospital receiving from the therapy that they were having. And here is the important bit that we actually wanted to know their perspective about the treatment. The answer to the question about how effective is CBT in helping you manage your tinnitus, 90% of the patients rated the effectiveness of CBT as 7 or above out of 10. So it was a 0 to 10 Likert scale for them to choose. 10 would be very effective, 0 would be not effective at all. And the second question was, are you able to manage your tinnitus or hyperacusis differently compared to before you started the treatment? 87% rated that as 7 or above. And how acceptable was audiologist delivered CBT to you? And 97% rated the acceptability of audiology delivered CBT as 7 or above, which is fantastic as far as we were concerned, because we were not sure whether patients would actually be happy to receive this type of intervention in an audiology clinic, but the data proves that they were absolutely happy and find that relevant. Now, I presented a lot of percentages and scores, and I can go on forever presenting statistical analysis. And but I'd like to read a few lines from The Little Prince, the story by Antoine de Saint-Exupéry, and to take some lessons from that. Grown-ups like numbers. When you tell them about a new friend, they never ask questions about what really matters. They never ask, what does his voice sound like? What games does he like best? Does he collect butterflies? They ask, how old is he? How many brothers does he have? How much does he weigh? How much money does he have? Only then do they think they know him. If you tell grown-ups, I saw a beautiful red brick house with geraniums at the windows and doves at the roof, they won't be able to imagine such a house. You have to tell them, I saw a house worth 1,000 francs or euros. Then they exclaim, what a pretty house. So this is big consistent with our over-reliance on numbers and statistical analysis, and perhaps not paying as much attention to what the patient's experience is. And I want to instead of going on the numbers, I'd like to read a feedback from a patient who received audiologist-delivered CBT for their tinnitus, and to be consistent with the passage that I read from Antoine de Saint-Exupéry. So, I think tinnitus is very specific condition that is very difficult to appreciate if you have not experienced it or you are not an expert in audiology. It is a condition that is with you all the time, at work or at rest. It is inside your own head and feels inescapable. It is not an outside problem or an external issue to be resolved. And to have someone understand that and combine it with knowledge of hearing, hearing loss, and hyperacusis, etc., it is extremely important. I have had more general CBT for other issues in the past and think the targeted CBT approach in the audiology department made the CBT treatment as useful and relevant as it could be. And I'd like to thank all of you with this slide. So I don't know whether we have time for questions.
Thank you for your excellent presentation, Dr. Aazh. There is a question about CBT, and I would like to see that the question is there a chance for relapse in CBT for tinnitus?
Is there a chance for relaxing CBT?
Relapse, that means like coming back, returning of the tinnitus after the CBT treatment.
Yeah, absolutely. Well, tinnitus itself doesn't really change much with the CBT. It's not even the aim of the treatment. The aim is the person to be able to hear, essentially the ultimate goal of CBT for tinnitus is the person to be able to hear the loudest possible tinnitus, but with no impact on them. So to be able to sleep, to be able to concentrate on their work, to be able to have no impact on their mood, enjoy their life fully with that presence of the tinnitus. So that's the ultimate goal of the tinnitus. And if people achieve that, and then whether it is possible for them to relapse and sometimes find it hard to actually do that, yes, it is a possibility. And so it can happen.
Excellent. Thank you very much. I'd like to thank you again. We have another 12 minutes, and I have prepared a 1-hour presentation for all of you, but I'm going to take the time only for 10-12 minutes to talk about my point of view about tinnitus management. I definitely learned a lot from the other presenters, and I'd like to just, I'm going to start sharing my screen, and hopefully I'll be able to have some information shared with you about the audiological management of tinnitus. Most of the things that I heard from the other presenters, I respect that. And that's the challenge of the science, that, you know, we listen, we examine the different approaches, and ultimately we want to see what we are going to help our patients. So I want to very briefly tell you that the whole goal of this workshop was to help the clinicians to understand that the tinnitus is actually a manageable condition. We can help patients to control their reaction to tinnitus and actually live with it in a very normal way, and tinnitus can become a part of them, a part of even of their personality, and they will be able to have a normal life. So I want to tell you that tinnitus is the malady of the 21st century. Many people in the world, around the world, I have estimated around 600 million people suffer from tinnitus. So it's a big number. It's a big challenge for clinicians like us to improve the quality of life for many patients. So, and it has been throughout the history, it has been with us. This is not a new thing. I always tell my patients and my students that the first time that we took a hammer in our hand and start banging on metals, it generates a noise, and of course it caused tinnitus for many people. So for thousands of years, Egyptians, Persians, Assyrians, like Europeans, all of us have worked on this to understand what the tinnitus is and how we can cure it, how we can manage it. And I can tell you that no one has a magic pill, no one has a quick fix, but tinnitus, again, I emphasize, it's a manageable condition that we can definitely help patients. So many people, as I told you, have worked on tinnitus, and it has had many impact on art, on science, on religion, on politics. So this is a real phenomenon that's happening, and it can influence many people's lives. So I don't want to repeat the things that we already have talked about, but I just want to bring your attention to this slide. We did a study a few years ago, almost 20 years ago. These are the things that people were told by their clinicians, that go and live with it, nothing can be done. I heard from one of the patients that the clinician told the patient that if you had cancer, I could cure you. Or people like you usually kill themselves. So be aware that how we react and how we respond to the patient is extremely important. How we feel their problem, and then how we can help them to manage their condition. So many ways we can manage the tinnitus. Dr. Alfarghal gave us a really good medical approach for tinnitus evaluation and understanding. But eventually, if a patient with pulsatile tinnitus or clicking in their heads or subjective tinnitus, any sort of tinnitus, eventually when they come to you, after all of these nice evaluations that we have had with the MRIs and CAT scans and MRAs and all of those 3D imaging of the brain, now we are at the point that the patient tells you that, okay, what can you do for me? I cannot sleep, I cannot function. So our job is to make sure that after removing all of the different factors that may have been contributed to tinnitus, when we find no medical or surgical approach to treat it, or medical or medicinal approach to treat it, there are many other approaches that can be applied to make the tinnitus to become more under control. So we talked about this on interview, audiological evaluation, tinnitus assessment. Although some people do not believe in tinnitus assessment, I personally believe in tinnitus assessment, and I will prove it to you. I mean, it's like when you don't do tinnitus assessment, it's as if you're not doing a hearing test and giving a hearing aid to a patient. Tinnitus assessment becomes important because, especially if you're using the hearing aids to treat them, if you're using the sound generators to treat them, if you're using neuromonics, the synchro, many other methods that you're using to help the patient. So those information that you're collecting is actually helping you to manage the tinnitus in a better way. So questionnaires that our scientists and collaborators mentioned about those, routine audiological testing. I usually try not to do acoustic reflex testing, especially for those with hyperacusis and sound sensitivity and tinnitus. I try to get my information about the patient and from a different approach. The tinnitus evaluation, Dr. Alfarghal mentioned these. These are important because if your patient has a high frequency tinnitus and you're not sure about it, so providing a signal that you're trying to mask or partially mask or manage the tinnitus with the use of sound therapy or hearing aids at a region that doesn't belong to the tinnitus, is going to be a little bit misleading. So yes, it may not be a very kind of important part of your tinnitus management, but is a very useful part of your management. And I highly recommend that you do these studies, especially about residual inhibition. I mean, residual inhibition is a real phenomenon that's happening in the brain. And sometimes when you give a noise to the patient's ear and it suppresses their tinnitus for a few minutes, it gives them hope that there's a way that externally my tinnitus can be manipulated. So that residual inhibition is a transient reduction in tinnitus loudness after you introduce a signal. So many treatment categories have been offered to the patients. Relaxation therapy, meditation, hypnotherapy, yoga, medication therapy, CBT, biofeedback, neurobiofeedback, sound therapy, acoustic therapy, counseling, TRT, tinnitus habituation therapy, all of these are there for you. It is your personal choice, in my opinion, that which approach you want to use to help the patient. But eventually, it is our patients, it is our responsibility to give them a normal life, at least with regard to tinnitus. Especially in this season of pandemic, I'm sure that you're seeing many patients with stress, increased levels of stress and anxiety. So that becomes extremely important to work on our counseling skills, work on our CBT, work on ways that we can reduce that emotional response to these unwanted stimuli. So medication therapy has been used. but there's not much of evidence for that it actually can help many people. RTMS, the repetitive transcranial magnetic stimulation has been used, electrical stimulation has been used. So these are some of the methods that can become maybe sometimes as a routine in the clinic in the future. But we do not have a lot of, science and evidence that it can help many, like maybe 20 to 30% of the population can get some sort of relief with these type of methods. But how to manage tinnitus, reduction of stress and anxiety, as my colleagues mentioned, are extremely important. So seeing a glass full, like half full, as half full, not as half empty is important. So giving a lot of emotional supports and counseling and psychological support to the patient becomes extremely important. Dr. Aazh talked about his beautiful studies on CBT, and CBT has shown to be one of the effective and evidence-based treatment methods for tinnitus. And he talked about his model. Hearing loss and tinnitus are related. Hearing loss, when you address hearing loss with the hearing aids or amplification or cochlear implants, most of the times, honestly, tinnitus moves to the background. With a few sessions of counseling and maybe a modified cognitive behavioral therapy that we offer in the US, we can definitely remove that emotional attachment that the patient has to tinnitus. And I can promise you that many of the patients actually with hearing loss, when you fit them with proper amplification, when you fit them with devices that provide soothing signals, it takes the edge off of the tinnitus and helps them significantly. So amplification has been used. Many scientists have shown the effectiveness of this in taking the edge off of the tinnitus. Yes, tinnitus may not go away. I mean, none of the methods that we have talked about today, none of them are going to take the tinnitus away. We don't have a magic pill. I have a list of thousands of people waiting for my email to send it to them. Okay, I got your magic pill. I got your quick fix. We don't have that yet. But what we know that almost 90% of the patients with tinnitus are actually curable or manageable. Yes, tinnitus will be there, but the reaction, the response, the attention to it will be diminished tremendously. So tinnitus masking has been offered by Vernon, the founder of American Tinnitus Association. Many of us have heard of his name and it's the work that he has done, the commitment that he has done for tinnitus. Tinnitus retraining therapy by Jastroboffs, Powell, and Margaret Jastroboffs has been a very effective method. Progressive tinnitus management therapy by Henry has been extremely helpful. These are all methods available for us. We can employ them and help the patients with tinnitus. Sound therapy has shown to be very effective. It can come from your smartphones, computers. You can even make sounds for the patients and introduce them to them, soothing signals. There are apps for it. So the technology has reached to that level. You can even stream signals from their smartphones to their hearing devices. So all of these are available for us. Breathing techniques, relaxation techniques. There are many apps that are available that can help the patient. I have seen studies that came out from Egypt when I was reviewing studies for journals. They have applied the relaxation techniques, Zen therapy, via using the apps, and they have shown significant reduction in the tinnitus perception for many people. Habituation is the factor. A key factor. Rich Tyler has worked on habituation. It's just to help change the disappearance of the reaction to tinnitus. So as Dr. Alfarghal mentioned, the sound of the refrigerator, the sound of the air conditioner is there, but we have habituated to it. So why not? Why not habituate to tinnitus? In general, if something, neuroscientists believe that if something happens in the brain, there must be something in the brain to fix it too. So if tinnitus is, if you call it as a brain function, so we can rewire the brain. We can retrain the brain. We'll be able to help many patients with tinnitus. So again, the goal of the habituation is the patients will habituate to their tinnitus, and they will habituate to the emotional reaction that it provides. And American Academy of Otolaryngology and Head and Neck Surgery, in collaboration with more than 50 scientists, they have come up with provided some practice guidelines for us, for many of us in the clinics, and it has shown that sound therapy can be as an effective method for many of us. So we talked about partial masking and total masking. I'm not, because of time limitation, I'm not going to go for that. I'm going to give time for people to ask questions. Studies that Hashir talked have been, with parental mental health. This is one of the studies that Hashir, Aazh, and our group has done. And we basically figured out that the parental mental health is extremely important. If your patient had anxiety and stress and depression in their family history, that's going to impede the treatment of tinnitus for you. So you need to explore that. Look at the whole picture, the whole family, the whole history, because we have evidence that parental mental health can influence the perception about tinnitus and hyperacusis in children and adults with tinnitus. So we published a few papers in here. I will make sure that I will send the PDF to Dr.Alfarghal, and you will be able to access to all of these articles. In summary, 1-minute summary, we have ample amount of knowledge to help tinnitus patients. We are capable of providing tinnitus rehabilitation and counseling and management. And unfortunately, the idea in medical community, most of the times, that tinnitus is not curable. I hear it every day in my practice, every day, that my doctor told me that nothing can be done. So we need to educate our colleagues. Actually, Vernon had a very nice, I'm going to bring a very important quote from Vernon, Jack Vernon, the founder of American Tinnitus Association in 1975. He said that if a clinician tells the patient nothing can be done, that means that they are not reading the articles. They are not reading the current literature. Tinnitus is extremely manageable. We just need to provide that passion and compassion and empathy to our patients, so they will understand that it is doable. So again, most of the healthcare professionals trust the work of audiologists in tinnitus management, and clinical practice of audiology should include management programs about tinnitus and sound sensitivity in daily and routine activities. So take-home message, there are many methods which can help tinnitus patients. Incorporating some of these methods into your office or your private practice or clinical practice is essential for patient care and the support that you're providing for them. Thank you very much for listening. I'm going to open our chats. We have a few more minutes, so if you have any questions, let me see. I'm going to stop my screen and go to the chats to see if there are any burning questions.
Professor, we have time. If you have the time, spend more time.
Okay,
Audience.
I have time. I just don't want to be kind of taking a lot of audience.
No, Professor, believe me, people very, very excited and appreciating the very valuable workshop you prepared. So take some extra time, please. I think most of the audience would love this.
Okay, so I'm going to take around, if you don't mind, I'm going to take another 10-15 minutes to talk about the questions. And then the question that I'm going to present, the question was about, it's from MJ, and thanks all, with attention to neuromodulation methods like TDCS, the direct current stimulation that some clinics have tried, the RTMS and CR neuromodulation in treatment of tinnitus, what is the future position of tinnitus management? And methods like CBT, TRT, and from your opinion. So this questionnaire is asking, this person is asking that, so if the RCBT, if the RTMS is here, if the TDCS is here, and they are evolving, so what would happen to CBT, TRT, and other options? I can tell you that all of these options are valid. I mean, we just need to have scientific evidence of their efficacy and how important they can help, at what level they can help us, what is their success rate. CBT has a high success rate, and we have evidence for that. We're collecting many studies about sound therapy, that the number of sound therapy combined with counseling, the number of articles have increased tremendously recently. So we are increasing the evidence, scientific evidence for this. The RTMS and TDCS, we have some evidence for it. It is okay. I mean, all of you know that tinnitus has many reasons for it. There's no single reason for tinnitus. So it is okay to have multiple types of management for tinnitus. There is nothing wrong with that. And then the question is, the question about the telephone application for TRT, I don't think that, I think the person who asked this question is about the telephone application for tinnitus. Dr. Aazh, if you don't mind, share that telephone app that you have devised for clinicians to help them for their tinnitus patients, please.
Yes, thank you very much. And so if you were going to, because during this COVID-19 lockdown in many countries, a lot of clinicians needed to basically give the patients a call and ask them questions, screen for the severity of the tinnitus, and also advise accordingly. And so there is this tinnitus questionnaire for telephone interviews that basically is developed for that very purpose. And I just shared my screen with you to give you a quick view of what this is about. So this is the question. If you go to the website of tinnitustherapy.org.uk, so under the assessment tools, it's a free tool to use. And basically this provides you with information that you need to ask during that telephone interview with your patient. And so if you add your own name, code or pseudonym for the patient, and your own email address, while you're talking to the patients on the phone, the questions that you ask them and rate them, then at the end, you can then submit this, and a copy of this will go to your own email address without it being saved anywhere else. And you can use this information to triage your patient that you talked over phone, and make sure that if they have anxiety, depression, suicidal thoughts, or need advice. So all of those information, you can gather them in a systematic manner and then act on them when needed. This is what I have created for this.
Thank you, Dr. Aazh. So there is another question. I guess the best person who answers this is Dr. Salvi. Dr. Salvi, one of the audience, Merdad, has asked, is there any physiological evidence on GABA issue? Like, can you talk to us, please explain to us about the effects of, like, the interaction of GABA and tinnitus, please, sir? You're mute. Yes, go ahead, please.
So we've done some studies with Don Kasperi after noise-induced hearing loss. One of the things that seems like it happens is the inhibitory neurotransmitter levels seem like they decline. This fits in quite nicely with the enhanced central gain. you can imagine driving a car with your foot on the brake and your foot on the gas pedal. You can make the car go much faster if you take the foot off the gas pedal. That's like taking away the GABA-mediated inhibition. So hearing loss in general seems like it depresses the inhibitory circuitries in the central nervous system. In terms of a treatment therapy, whether you can increase the GABA levels to suppress the tinnitus, that's really unclear right now. I don't think there's any drugs in the GABA category that have unequivocally proven to be effective in treating tinnitus. I don't really have a comprehensive or clear answer on this, except from the biological points.
Thank you, Professor Salvi. There's a question also for Dr. Aazh. This was sent privately to me by one of our colleagues. And the question is to you, Dr. Aazh. The pre-post CBT treatment shows little improvement in tinnitus sound loudness. And that was shown on your slide. Have you tried to use a combination of CBT and the noise generator for a better effect?
Not really. And the small reduction that was in the tinnitus loudness, as was measured by the visual analog scale, to me it seems like that it is where, you know, we can't really conclude that tinnitus was actually quieter. So I think probably if they were managing it better, they were less noticing it. But in terms of combining sound therapy methods and CBT, there's this discrepancy between the two. One wants to accept tinnitus as it is, which would be the CBT, and one wants to avoid tinnitus, which would be the sound therapy. And both of them are legitimate coping strategies. There are lots of things in life that as human beings, we can't cope with. Therefore, we take this coping strategy of avoidance. We avoid it. And that works well for lots of different things. I don't think it's the ideal for tinnitus because it's always with you. It's very, very difficult to avoid tinnitus. And the alternative way is to go that path of acceptance of tinnitus, which would be the use of the CBT skills and the other therapies in that form.
Excellent, thank you. So this question came from California, and this maybe Dr. Alfarghal can answer this question. So he's asking, we have seen an increase in tinnitus assessments in our clinic post stay at home, like during the COVID situation that all of us are experiencing. I currently use THI and will be using TRQ. Can you make a recommendation about questionnaires? What other questionnaires you recommend our colleague can use?
For our clinic, we use only mainly the tinnitus handicap inventory because we have a validated Arabic version. So we tried with the functional tinnitus index, but because it's copyrighted and we don't have a validated Arabic version. So I think you can answer, Professor, because we have a limitation because we need a validated Arabic version. So if you don't have the validated Arabic version, we cannot use the questionnaire.
Okay, and thank you, Dr. Moahamd. So what I can tell you, add to this is I personally use THI and TRQ. TFI is extremely becoming popular. Tinnitus Functional Index, or Amit, I'll suggest that you use Tinnitus Functional Index also. There's also a questionnaire from Cleveland Clinic that looks at the effect of hearing loss and tinnitus. It's just off of my head the name now, but it has a question that compares the impact of tinnitus and hearing loss on the person's daily activity. And most of the times you can see that when you study this questionnaire, I think it's SPOT, I think. When you study this questionnaire, you can see that the patient is actually complaining more about hearing loss rather than to tinnitus. So differentiating between these two problems can become very helpful. Thanks for the question. And next question is,
sorry, Dr. Danesh, can I just make a comment?
please.
Is because it was very interesting about COVID lockdown and tinnitus problem. I actually recently done a study on how a comparison of during the lockdown scores on visual analog scale of tinnitus loudness, tinnitus annoyance, and effect of tinnitus on life compared to the previous before the lockdown score of patients, and there was actually no significant difference between the tinnitus loudness and annoyance when we make the comparison. So tinnitus remained as loud as what it was and as annoying as it was. But very interestingly, the scale on effect of tinnitus on life during the lockdown was slightly lower than before the lockdown. And that made us think that maybe factors bigger than tinnitus are impacting on the person's life, and that's somehow impacting on that. And also the person is not doing as much as activities that they used to do, so it is not interrupting work or etc. So somehow the effect of tinnitus on the person's life were not as rated as big as before the lockdown.
Interesting. I would like to see your research hopefully soon published so we can all enjoy reading it. There's a question from one of our audience that he or she is asking how hearing aid is useful in tinnitus. Well, that's a very interesting question. I mean, the simple explanation that I can give you, if you ask from many tinnitus patients, that if you go to a restaurant or a meeting or when several people are interacting, there's a background noise, do you hear your tinnitus? And most of them say, no, I don't hear my tinnitus. And the reason is that because other sounds are pretty much masking his tinnitus or her tinnitus. So that's why the hearing aids can provide some sort of amplification that can basically interact the patient's brain with the tinnitus. So they will have less attention to their tinnitus. And one thing that I can tell you that when we talk to many of these patients, as I told you, with the patient, especially with the patients with hearing loss, what happens is the first thing that they are concentrating when they communicate with people is their tinnitus, because they are straining to hear. When they're investing energy or wasting energy actually in order to hear, and the first thing that they hear in there is their tinnitus. And they tell you that, oh my God, this tinnitus is not helping me. I cannot hear people because of my tinnitus. Then you measure their tinnitus less than 5 decibels, 3 decibel sensation level. How a 3 decibel sensation level can mask speech for others. So that's why that it is like I have had patients with 1 dB sensation level of tinnitus and their reaction was like 98 on their THI, and I had patients with 20 dB sensation level tinnitus, very extremely loud, and then their reaction was in 50s. So what makes this difference is your interpretation of the signal. It's like going to a dentist. Many of us, when we go to the dentist, we sit on the chair. Actually, I have a dentist in 2 hours that I have to go. So you sit on the chair, nothing, you don't have any emotional response, but there are many people, as soon as they see the dentist chair, they start shaking and they feel pain. It's how we react to the stimulus. And our job as clinicians is to change that emotional reaction to it, either with hearing aids, sound therapy, counseling, CBT, compassionate listening to the patients. Become an active listener. When we talk about counseling to our students and clinicians, we tell them that become a good listener. Spend time with your patient. The medical model, unfortunately, doesn't have time to spend with the patient. There are 200 people are waiting to be seen, and a surgeon doesn't have time to spend time with the patient. explaining their tinnitus. That's why that we need experts like you who will spend time with the patients, listen to them, and try to solve their problem.
Professor, just I have a request from you.
Yes.
You hear me? So,
Yes.
Professor, we need advice from you as an expert clinician and professor. Many of the audiology training programs in different parts of the world, they don't give enough training to be empowered to clinically manage tinnitus patients. And some of the audiologists in different parts of the world, they seek some broad line guidance, how really they acquire the essential clinical competencies to handle tinnitus. So what's they have to do, what the important thing is they do to be competent to handle tinnitus patients?
Excellent question, Alfarghal. I mean, I'd call you in your first name because I really respect
Professor. You are my professor.
So what we have is a very good question. First of all, most of the programs in the US, the audiology program, they have a course specifically designed for tinnitus. And I have always recommended, I was on board in designing courses for many schools. So I have been recommending a course on tinnitus, just how to train a clinician in their 4-year program of their audiology, doctorate audiology program, to learn about tinnitus. So many universities, actually many AUD programs and many PhD programs, they have a course specifically designed for tinnitus. That's number one. It's the thing that we did for genetics. As you know, that many schools didn't have a genetics for hearing loss. Now, in many doctoral programs in the US and or other countries, there is a genetic course. So because we introduce genetic training to the audiologists. So what we have is, yes, there are some schools that offer it, but there are workshops. Jasabov has workshop, Tyler has workshop. I mean, there are many places are making, American Institute of Balance has workshops. The Hashir Aazh has an excellent workshop. Dr. Begley has workshop. There are many of these places that actually are, they have different approaches. Like the ones that you see, each of them, they have their own approach. You remember that tinnitus does not have any one single reason for it, so the treatment for it can be also wide. There are many reasons for tinnitus, so the treatments can be wide, but we have the opportunity to learn from these experts from all over the world. So I'm getting, Dr. Alfarghal, I'm getting a lot of questions. So because of, we're gonna continue 6 more minutes to answer some of these questions. And then I want to say goodbye to all of you and wish you a happy rest of the day or night. And so, question is asking, is there a difference between tinnitus due to cochlear damage, which is such as noise exposure, to neuropathy or endolymphatic hydrops, etc.? What medical drugs can do with them and with the CBT? So my answer to this question, I'm going to answer this, but I would like to other presenters also contribute to this. My answer to this is yes. Let me tell you something. Number one, Dr. Tyler in University of Iowa did a study. He gave questionnaires to people that, okay, this is medication, this is hearing aid, this is sound generator, this is electrical stimulation, all of the treatments, and ask them, so which one of these you prefer to spend money on them to get treated? Guess what? What people used and chose, all of them, or not all of them, a high percentage of them used medications or chose medications. Why? Because it's easier. I mean, taking a pill is easier than putting a hearing aid on or going to counseling sessions with Dr. Aazh. So people chose medications because it was faster, it was easier, it was available. However, we know that medications do not work. most of the times. So when the patients come to us, they have already tried all sorts of medications, but it hasn't worked. They have tried supplements, lipoflavonoid, tinnitus archers, many of them, vitamins. They have not removed the tinnitus. Maybe they have reduced it, but they have not removed the tinnitus. And we don't have any method in the world at the present time, as far as I know, with my limited knowledge, that can completely eliminate tinnitus. Yes, once in a while we have patients that, Dr. Danesh, I don't hear my tinnitus. It's gone. Yes, I said, good for you. You're one of the lucky people. But many people will have tinnitus for the rest of their lives. I have tinnitus myself, but my tinnitus is not bothering me anymore because my brain has habituated to it. I hear it loud and clear, but it doesn't interfere with my concentration, my sleep, my daily activities, or my attention. So if I can put my patients at that level of understanding and management for the tinnitus, then I'll be able to function better. Something is going on, Dr. Alfarghal, on my screen. So I guess we are getting close. So do you want to add something to this?
I think you did a great job, Professor. A lot of very beneficial information from real experts, a lot of clarification of misconceptions in the tinnitus practice. I think also we have very positive feedback, and we have the largest audience in all our series of webinars. And I think you motivated the people, Professor, to learn more about the proper protocols for management. And I think many people will think to improve their practice with the insights they obtained from this webinar. And we are looking for more collaboration and more work to be done to help clinicians and audiologists in different parts of the world to improve their services for the tinnitus patients.
Thank you, Dr. Alfarghal. I just want to end with one sentence. Please, first of all, I wish you all be safe and healthy. Second thing is that never say no. This is the thing that I tell my students. Never say no to your tinnitus patients. Tinnitus is actually very manageable. When you put that white coat on and you look at the patient who's sitting on the chair, okay, I can't do anything for you, that completely disturbs them and makes their tinnitus actually louder. Listen to them, work hard. Your tinnitus patients, I can tell you that 90% of the tinnitus patients are manageable, and I'm sure that all of us will be successful in helping them. Thank you very much again for this opportunity. Thank you, Dr. Salvi. Thank you, Dr. Aazh. Thank you, Dr. Alfarghal. It was an amazing meeting. We had almost 150, 160 audience, which is very good for a Saturday morning in here, or late night in Middle East, or India, or South America, or Brazil, or Canada, or California, or US, every place. Thank you very much. Thank you, Dr. Salvi. And
thank you very much. You did a great job organizing this, and glad to meet you, Mohammed. And
it's an honor, Professor.
Thank you, Hashir. Yeah.
So long.
Thanks to all.
It's an honor, really.
And the recording will be available. Dr. Alfarghal will
sure.
upload.
Sure, yeah, sure.
Thank you. Bye.
Thank you. Goodbye.